Welcome. Glad you're still well and smiling, Rick. Would you care to introduce yourself?
Sure. I'm Rick Loftus. I'm an internist, late of Eisenhower. Also a principal investigator with Palm Tree Clinical Research. We've done mostly clinical trials on HIV salvage medications, and I've done some diabetes work. Lately, we've been doing more COVID projects. We're planning to bring the Merck measles vector COVID vaccine to the area. Merck is still trying to figure out their dosing. So it looks like our start time for that will be spring rather than winter. But we're hoping to bring in some other projects maybe before then that are COVID related. And I am probably going to talk a little bit about vaccines and about monoclonal antibodies and kind of the general situation for COVID locally and otherwise. And we can definitely take comments from the group. I'll trust you, Jonathan, to facilitate that. Do you want me to just kind of spiel for a little bit and kind of?
Yes, please. You're a good spieler.
Okay. Yeah, I'm always worried I won't have anything to say, and I guess it's the Irish, but we always seem to use up all the time. So I think the big excitement this past week, of course, was the news about the Pfizer and Moderna vaccines. Both of those are RNA vaccines. Well, we have one RNA vaccine in veterinary medicine. And although we had a couple developed for HIV, they never kind of went anywhere in terms of coming to the clinic. So these are the first RNA vaccines that will be used in people, in humans. The efficacy was very high. The FDA's threshold for a vaccine being approvable is about 50% protection. And in fact, what we saw with the Moderna and Pfizer vaccines was about 95% protection from severe illness. And the good news also was that they are just as effective from the look of it in adults over 65 as is true for younger adults. And that is a little unusual because many vaccines don't work as well in older adults. Many of you may, for example, know that there's a higher dose influenza vaccine for people in their 60s and above. And that's because, the regular flu vaccine doesn't seem to stimulate as strong an immune reaction in older adults. It does not look like we're going to have that problem with the RNA vaccines. They are looking safe, although to be fair, if there are side effects that won't show up for 6 months to a year, we haven't had these vaccines around that long because you'll all remember that the anniversary of the announcement of the discovery of this new virus was almost exactly a year ago. It was a year and like five days ago. So we haven't had these RNA vaccines in human beings long enough to know if there's some longer term side effects. But so far they look reasonably safe. People get some fevers, they get sore muscles at the site of injection. Really nothing that sounds too much different, honestly, than like a tetanus vaccination. So all of that is very, very good news. There is a little bit of, I think, some confusion or maybe just a lack of clarity right now about how vaccines will be distributed. The FDA has outlined 4 phases of distribution, starting with frontline healthcare workers and people who have comorbid conditions that put them at risk of severe COVID. I don't have the FDA manual to know which conditions are considered, likely for severe, but I would think it would be things like poorly controlled diabetes, high blood pressure, heart diseases, that kind of thing. Phase 2 then includes adults who are at risk of moderate COVID. And again, I don't have the list yet of what, comorbid conditions are considered phase 2 versus phase 1. Other essential workers are covered in phase 2. But apparently the way the Trump administration is doing this is, first of all, they're using the military to distribute the vaccines. Pfizer has said they can produce about 40 million doses. but it's a 2-dose vaccine. So that means 20 million courses of vaccination from Pfizer. It's probably going to be a similar number for Moderna. So that winds up being altogether probably in the neighborhood of 35 million people, and that's about a tenth of the US population. Oxford also released some information about the Oxford/AstraZeneca vaccine. The closest trial site for that vaccine in our region is El Centro. Clínicas de Salud is doing the Oxford vaccine. I think the closest location to our region for the Moderna vaccine is Banning, and I'm not aware of any locations that are doing the Pfizer vaccine in the Inland Empire. But, you know, in terms of what we're trying to do with the vaccinations, we are, the goal with protecting a population from a disease is to produce protective immunity. And, we think for SARS-CoV-2, we think it's probably at least 60% of the populace has immune reactions, immune protection against the virus. Right now, our best estimates, we have about 12 million adults that have been confirmed positive for SARS-CoV-2 out of, US population of about 360 million people, something like that. So 12 million confirmed positive, but in most countries, we know that the number of folks who get a positive test is a fraction of all the people who have the disease. And the estimate has been anywhere from probably 3 to 10 times as many people in your population have COVID as are getting the test and confirming they're positive. So the smart people that I listen to in the epidemiology and virology realms are guessing we're probably looking at something like maybe 60 million Americans have already been infected. I know in South Dakota, where I have a ranch, it's probably at least 35% of the total population of South Dakota has COVID right now. And most of them have been infected in the last 6 weeks, which is why they're completely overwhelmed in terms of their healthcare system. In fact, the entire Midwest is on fire as far as that goes. Actually, a lot of the South Dakota patients are now being shipped out to hospitals in Washington State, Oregon, even Wyoming, which doesn't exactly have a lot of ICU space to go around to begin with, because Wyoming's tiny. But, we can talk a little bit later in this call about public health measures and how well the populace abides by common sense things like staying home, washing their hands, wearing masks. There was a paper that came out today that looked at Kansas, very interestingly. This is kind of a digression into masking. The state of Kansas declared a mandatory mask rule, but allowed counties to opt out for some crazy reason, because Kansas. And the counties that abided by the state masking rule saw a decline in their new COVID diagnoses. The counties in Kansas that elected not to enforce a mask mandate all had escalating case rates of COVID. We saw that in Arizona as well. When Arizona put in their mask mandate, their COVID rates came down. It's not rocket science. I had to deal with nurses even at my own hospital who said, I'm not sure that masks work. And I'm like, here's 18 different papers that show that masking does in fact work for this. Shut up. I had another nurse who mouthed off about, I don't think lockdowns work. It's like, we have lots of papers now on that as well. Like, this is science. You don't get to have an opinion. It's data and it's real. So, but getting back to kind of the relationship between what's going on with natural infections and what's going on with vaccination, we really, really, really want people to be immune to COVID from vaccinations, because vaccinations do not disable you. Vaccinations do not kill you. Natural infection can do either one of those. There was a paper that came out literally like 10 minutes before I got on this call looking at the infection fatality rate for COVID. And when you're in the age range of ages 5 through 9, COVID or SARS-CoV-2 is no more lethal than the flu is. That is to say, it's very unusual to have fatalities in little kids from either one of these viruses. And that doesn't mean, by the way, that little kids can't get infected. There's been this kind of stupidity among the white people of Western countries After China published all kinds of stuff about schools in Guangdong and little kids all over China being infected by COVID, shedding COVID, infecting their grandmothers at home, I saw all these Caucasian scientists, like this virologist in Australia, just kept saying, "We can keep our schools open because children don't transmit this." And it's like, there's a pediatric literature already from China. Are you saying that the Chinese children are biologically different from white kids? Because that's not true. Why would you think that the Australian children can't get infected and pass this on the way the Chinese kids do? Ultimately, what we've learned is that what's going on in schools as far as kids passing along SARS-CoV-2 and COVID is comparable to what's going on in their larger community. So if you have a community that's doing stupid stuff like letting indoor restaurants operate and keeping the bars open and maybe keeping indoor gyms open, you're going to have a lot of COVID in that community, and that's going to spill over into the children. And then the children are going to be spreading COVID to their families who maybe don't have it yet because they're going to pick it up from their schoolmates whose parents and older siblings have contracted it in the community. New York City, as you may all know, had a bit of a controversy this week because they shut down live school, which has a huge impact on people's ability to work, because if their kids aren't going to school, then they have to stay home to watch them. The COVID incident rate in the schools of New York City amongst the children is 0.17% testing positive of all the COVID tests administered, which is a super, super low rate. And that's part of why the parents in New York were so upset, because the citywide COVID test rate for positivity had gone up to over 3%. And that was their criterion for shutting down the schools. And so even though the schools themselves have a really low rate, the worry is that it'll start to spill over into the schools. And so that's why the New York schools got shut down. But getting back to the bigger theme here, we would really prefer people to get immunity from vaccines, not from the disease. But unfortunately, the Americans are just like a herd of lemmings running off a cliff. I don't know if any of you saw those photographs from Sky Harbor in Arizona, but people have flooded the airports. They've been told not to travel for Thanksgiving, but they're doing it anyway. We already have data from Canada, whose Thanksgiving is a month earlier than ours. And 2 weeks after they had Canadian Thanksgiving, when their health authorities also told them, please don't travel for your Thanksgiving. And they did. And they're dealing with terrible surges in British Columbia, in Ontario, in Quebec, in Alberta. They're running out of beds. Manitoba is running out of hospital beds. And, we're going to have the same exact thing. We're already in the Midwest I think my brother lives in Minnesota, and eastern Minnesota had only like a few dozen hospital beds left in the entire eastern half of the state. Oklahoma has completely run out of ICU beds, so all their critical patients have to be shipped out to other states. South Dakota has run out of beds, and so they're now shipping their critical patients to other states, and those states are eventually going to run out of beds. So we're really in a dire situation already. And to see all of these, 40% of the Americans traveling for Thanksgiving dinner is just horrifying to the medical people. I had a recruiter talk to me about taking a job near my ranch in Rapid City. And I said, no, because it looks to me like the leaders in the Midwest want their healthcare workers to die. And I'm not going to work for a state that doesn't protect its healthcare workers. They're not making policies that will protect the nurses and doctors. I don't think people understand, my colleague Eli Perensevich in Iowa, who I, contact from time to time, who's he's a frontline physician, but he's also a scientist whose interest is on face shields and how they prevent spread of COVID. And he said, people are just going to walk, they don't seem to understand. As soon as we get through the immediate emergency, a lot of people are going to leave the Midwest for medical practice because they're too burned out and probably disgusted by what's happened. I don't think people in this country have really realized the crisis that's going on right now. I'm on a Twitter feed to exchange data with scientists and papers and commentaries on papers, and people are just burning out left and right. I really think we're going to run out of medical providers really soon. Even before the end of December, I think people are going to start walking. In the Ebola pandemic in Africa, they ran into a similar situation where there was an initial surge, and they coped. And then some doctors and nurses started to die of Ebola. And by the time they got about 2/3 of the way into the outbreak, they just had entire medical staffs just walk out of the hospital and just refuse to show up to work any longer because it had gotten too out of control and too dangerous. We are really close to that point in the United States. And watching all these people go to Thanksgiving dinner like it's no big thing, and everybody's in denial saying it's not going to be me. Well, it definitely is going to be some of them. And in fact, the high rates of COVID make it clear to me that they're going to pick up COVID in the airports. They're going to take it to their Thanksgiving dinner table. They're going to spread it to their elderly relatives who are going to need to be hospitalized, and there won't be beds left. And nobody wants to hear that because it's scary. But I'm not saying that to panic people. It's mathematical. And that is absolutely what's going to happen. And the medical scientists now are just tired of tearing their hair out. Like, how many times do we need to say it? You know, having the CDC announce this week, don't travel for Thanksgiving, you should have told people a month ago when they were making their travel plans. So this gets back to also the mismanagement of this pandemic by the Trump administration, where the proper medical authorities have been silenced until like this week, when Trump is so demoralized now about losing the election that he's not bothering to regulate anything. So he's letting the CDC talk now. But it's a month too late to warn people not to travel because it looks like a sizable chunk of our populace is doing so. We are going to see people dying in the parking lot because they can't even get into the emergency room in their respiratory distress. My family personally has decided to Zoom for Thanksgiving, Zoom for Christmas. We are not getting together. We are not traveling because it's too dangerous. And I've just told everyone, my sister has in-laws who are planning to get their very large family together for Thanksgiving. And she was feeling very uncomfortable about that, as was her husband. And she wasn't sure how to tell them politely, like, I can't do that because it's too dangerous. But fortunately, they talked it out and they decided to cancel. So that family also isn't getting together for Thanksgiving this year because it's just too dangerous, even though they live in the San Francisco Bay Area, which until last week was actually doing pretty well compared to down here. San Francisco's COVID rates are about 1/10 of what they are here in Riverside County. So, or at least in the Coachella Valley. But I've just kind of plummeted into all of the negative stuff. But getting back to the hopeful news, we do have, two very good RNA vaccines that look promising. The Oxford vaccine is a more conventional vaccine. That one also appears to produce higher levels of immunity than natural infection does. Besides the vaccine news itself, the other important thing that happened this week was that Shane Crotty, who is an immunologist at the La Jolla Institute of Immunology, released a study of immune responses to SARS-CoV-2. And he has concluded that although it's true that the antibody levels do wane, it looks like the strength of the immune reactions in most people are at a level where Dr. Crotty says, I expect people's immunity to last for years. He can only say with confidence 8 months, because that's as long as they've been watching the patients. And I guess, while they're having a very strong immune response out to month 8, you could sort of suggest that maybe they're going to lose all their immunity in the next month or two. But he says, the robustness and the high titers of these immune responses look to me like most people are going to hold on to immunity to this for years. Given that the immune responses to the vaccines look even stronger than what we see with natural infection, it suggests that we're not going to need to probably do an annual COVID shot the way we do annual flu shots. It doesn't look like we'll need boosters. It looks like we'll be able to get immunized and it will give us years of protection. It may turn out ultimately that we do boosters at 3 or 5 years or something like that. We won't really know until we follow along with the science. But, I'm very, very hopeful about the vaccines. I've heard people, including Tony Fauci, say, oh, people will start to get the vaccine in the, spring of 2021. Well, I told my family, regular folks, even folks that look like they may be a little bit more at risk, probably aren't going to start to see vaccination until summer. And I think some of that is just the logistics. Certainly having the transition of the Biden administration held up by the Trumpists isn't going to help because it's delaying getting the logistics around vaccine distribution and administration laid out, because that's going to be done under the Biden administration for the most part. So I do think there's going to be some logistics. And as much as people would like to say, oh, people are going to start getting vaccinated in the springtime, I think for the bulk of the population, just from a supply side and also from the logistics of distribution, I have a feeling that it will start to be sort of later summer before a lot of people start to see ample opportunity to get vaccinated. Will people who've had natural infection need to get vaccinated? Probably not. Will probably not, need to do that because they'll have immunity that looks like it'll be held on to for most people. Even with these handful of reinfection cases, we're not seeing dozens upon dozens upon dozens of reinfections, which, given how much SARS-CoV-2 is circulating, we definitely see if people were vulnerable. So it does look like, the protection is going to last a year or two for most people, and that's good news. So they probably don't need to get vaccinated. It likely will be that people might get tested for antibodies before they get vaccinated, because if they already have antibodies, they don't need to use up a vaccine. So that will finally be a good reason to get antibody levels checked by your doctor. So, as we lead up to, regular citizens being able to get the vaccine, which I think will be summertime, it may be a good idea before then to check for antibody levels. But I probably wouldn't do that until you've got your vaccination scheduled, because, there's a lot of time between now and when the vaccine will hit your arm. But I am very hopeful, and there is a light at the end of the tunnel. I just, like a lot of medical scientists, I just feel like we're going to have a whole lot of hurt between now and the spring, because we can't seem to get the Americans to do the basic things to protect themselves. And we're going to see a lot of needless death and disability from COVID over the winter time. So it's still looking like the worst is in front of us. We may see as many infections between now and February as we've seen through the entire pandemic up to this point.
Rick, why don't you take a little break, save your voice. I wanted to cover a few logistic things.
Sure.
Some people have submitted some questions, and for the most part, I've copied them and sent them to you in the chat.
Okay.
Separately, David from Coachella Valley submitted some questions in advance, and I copied those and sent them to you in your Gmail account. Okay. So if you get a chance to look at that, and then I'm gonna, because I can talk, I'm going to ask a question. What's to stop someone from getting 2 different vaccines? Is it
well? That's good.
worthwhile?
That's a good point. I think there's that could probably happen. Would there be any downside? Probably not. I don't think it would hurt people. We do say, for example, with the tetanus shot, that we don't want people to get their revaccinated too soon. So if you've had it in the last 5 years, we don't recommend it, because it can affect. They can get a strong reaction, for example, and that can be counterproductive. I don't know that we'd anticipate any negative side to getting vaccinated with more than one COVID vaccine. But I think we try to deter that from happening, because it's a waste of resources, because we'll only have a limited supply of the vaccine. So we want to make sure that we're getting one vaccination course to one person and not multiple different courses to the same person, because they only need the one from the look of it. Does that make sense? Did I answer your question?
Yes. So I've now sent 4 or 5 questions to you in chat.
Okay.
If you could take a look at those. And
so one question I saw is, do different types of vaccines provide different immune responses? Well, we haven't really had the details of the immunological profiles produced by these vaccines to compare them yet. So we don't know. That's a very good question, because the RNA vaccines, for people who don't know, so like I said, we don't have up till now any human vaccines that use RNA. The reason why we're excited is because we always knew that RNA vaccines were a type of vaccine that could be produced quickly if we needed them. And so that's why these got produced so fast, although we were able to produce some conventional vaccines as well, partly due to the fact that SARS-1 happened 17 years ago, and we sort of had some vaccines suitable to this situation kind of sort of ready, or at least halfway developed. So it's a good question as to whether the conventional vaccines will produce a different kind of immunity from the RNA vaccines. We probably won't know the answer to that until probably, well, actually, we probably have a better sense of that by the time the RNA vaccines start to become available to the average citizen in probably April, May, June of next year. We'll probably know whether there's any important differences between the types of vaccines. I see another question here about whether long COVID patients may benefit from the vaccines. I would say probably not. And the reason is because long COVID is a complication of having had a COVID infection. And so by definition, that person's immune system has already seen the virus. So protective immunity from a vaccine was certainly, producing neutralizing antibodies to prevent infection. Well, it's kind of late. They've already had the infection and the aftermath. And there's probably at least 4 different categories of long COVID. And each category has multiple different complications. For example, one category is one of my vital organs got harmed by having SARS-CoV-2. It could be your lungs. That's true for most people. Could be your kidneys, could be your heart. So that's one category. There's also people who seem to have kind of a chronic fatigue syndrome from having had COVID. That's a different category of long COVID. So we're still trying to kind of basically characterize what the different long-term complications are. It looks roughly like about 5% of COVID survivors have some form of complications, but we're still really early in characterizing how common it is to have disability or complications from acute COVID. We had one study that came out earlier this month that showed that about 40% of people 2 months after their hospitalization from COVID were still not back to work because of lingering symptoms. So that's a substantial number of people. So to be still not back to work 2 months from their acute infection. So this is why we keep trying to say to people, even if it doesn't kill you, you don't want to get this because you may wind up with significant, medical complications that may compromise your ability to work and function, even if it doesn't kill you. So I don't expect that there would be any benefits for long COVID from the vaccines, but I have been interested in looking at whether the monoclonal antibody that I studied earlier this year, leronlimab, which is a treatment to prevent the sort of complicated symptoms. Most people in their first week of SARS-CoV-2 infection have basically like viral yuckiness. They have like runny nose and cough and fever and things you'd expect kind of like the flu. It really, in the second and third weeks, that some people wind up needing a hospital, and it's because they wind up with an inflammatory effect from their immune system. At that point, the virus has run its course. I mean, for most mild COVIDs, after about 10 days, the person isn't even contagious any longer because the virus levels come down. Even people who wind up critically sick in the ICU, after about 20 days, they're not contagious with virus any longer. So the virus activity calms down, but then it's the immune reaction to the virus that winds up messing people up. We've started to figure out why some people get severe COVID and other people are fine. And it has to do with the function of their interferon system. Interferon is a chemical secreted by your immune cells, and it is the body's natural antiviral. It's kind of a broad spectrum antiviral substance that your body makes. We also use interferon to treat certain cancers. So it's an immune chemical that we make naturally. In fact, there's a variety of different interferons. And we know that in the test tube, if we throw interferon at SARS-CoV-2 virus, it squashes it like a bug. It is exquisitely sensitive to interferon. So it's probably not a surprise that if you're one of the unfortunate people who, either due to producing autoimmune antibodies that gum up your interferon system, or due to a genetic defect where you don't make interferon, you would wind up getting karate chopped by SARS-CoV-2 and get critically sick with COVID. So at least for some small fraction of severe COVID cases, it's their interferon system not working right that winds up being the problem. But getting back to long COVID, since the long COVID syndrome is more an aftermath of being infected, I don't think the vaccines would help people. But I do think some of the treatments that we use, that we're investigating to treat SARS-CoV-2 infection, may help prevent long COVID. And that's something I'd like to study. And I've talked to Cytodyne about doing such studies, but Right now, they're just focused on getting it approved for ICU use for COVID, and they need to get that approval before they can start making drug available to study other conditions. So,
Rick, there's
yeah.
more questions coming in on chat.
Okay, let me look here. Can you talk further about using face shields in addition to a mask? Yes, I'll make it brief. So Eli's really one of the experts on this, but in SARS-1, which got into Ontario and Ohio in the United States, the experience in Toronto was that's where they figured out that eye protection had a big influence on whether people contracted SARS-1. That people who had eye protection were less vulnerable. And we even had a case earlier this year of a physician who also he's one of the commentators on TV, who flew in an airplane and then contracted COVID from the flight. And he thinks it's because he didn't have eye protection and his eyes were exposed. So while we don't think that face shields by themselves are sufficiently protective, in fact, we have literature that shows that a face shield by itself doesn't really prevent spread of COVID and won't perfectly protect you because the particles are in the air. A mask will confer some protection, but this is why if you ever see any medical providers in photographs or on TV who are on COVID wards, they all have face shields, and it's because we don't consider people to be fully protected unless their eyes are protected. So I tell family members, if they're going to be in an indoor environment where they're worried they might have a serious COVID exposure, I want their masks to be on, but I also want them to have a face shield that is sealed across the forehead. I don't want there to be any loose space above their eyes, because if there's droplets coming down, I don't want them settling on people's eyes. So I want a solid seal across the forehead, and I want a shield all the way down past their chin. And that seems to be, I mean, we don't have absolute proof, but we do have some indication, based on the SARS-1 literature, that is protective. So that's what I recommend for family. And when people have had to travel, that's what I've asked them to do. I wear a face shield when I'm within 6 feet of other human beings at all times. What's your opinion on safety of outdoor gyms with reservations, masks, and disinfectants? They're not as low risk as staying home or working out in your backyard, but I do think that they are reasonable. I am familiar with the AOS one, and I think it's in Palm Desert, that has moved their operations outside. They should have done that 6 months ago. We're starting to appreciate that poorly ventilated indoor spaces is a big way that people get infected. I probably wouldn't want to be near the aerobics classes. We had a paper that came out of Korea that showed that an indoor gym that had an aerobics class did wind up with people in the classroom getting infected, even though they were physically distanced. And that's the whole thing that people like from the Harvard Chan School, the aerosol scientists have all been saying to us, the air needs to be well ventilated to protect people. So I think being outdoors goes a long way towards keeping people safe, but I probably wouldn't do an aerobic class at an outdoor gym. I'd probably do the machines. I've noticed that these gyms have rules about how long you can be there. They don't want anyone there longer than an hour. I'd probably suggest keep it to 30 minutes, do a quick workout, wear your mask. Everyone else there has to wear a mask. I think they're reasonable. I think in a perfect world, of course, we'd have everybody vaccinated and we could just go to indoor gyms. But I don't think we're at that point yet. And I think people are getting stir crazy. If this were only a 3-month period of having to put up with craziness, I'd say just stay home. But this is, we're going to need to sort of like not go crazy. And, people need to sort of figure out ways of doing things to feed their souls and not get themselves killed or exposed to COVID in the meantime. And I think, doing your gym work outdoors is a compromise that's reasonable. And exercise is a health building thing. It helps people's mental health as well. So I think there's a lot to recommend it. I would definitely not be the same about like patio dining. I am not personally going to eat on a patio in a restaurant. I'm only doing takeout, and and it's partly because people can't wear masks when they're eating. People at a gym can wear masks the whole time they're there. So I think the gym is a little bit of a different category. And I do think outdoor gyms have a lot to recommend them, because I think they're going to help people cope with the being cooped up stuff that we're still stuck with for the next few months until the vaccines get distributed in the middle of next year. What's the best
So,
disinfectant
Rick,
spray? Yeah.
I imagine going in for physical therapy, occupational therapy, speech therapy, which are all indoors, would be contraindicated from what you've mentioned.
Well, I think the physical therapy places, as far as I'm aware, are trying not to have multiple people in there at the same time. They are, indoor facilities are capable of adjusting their ventilation systems to be COVID friendly. It's just that most places haven't done that. But it's not like it cannot be done. There are many buildings that can be adjusted to have high levels of ventilation. And if they do that, then they're fine. And there are local HVAC businesses that are adjusting indoor environments to be well ventilated like airplanes are. Planes actually, as far as the air goes, are not a very dangerous environment for COVID. It's a lot of the other things that happen getting onto the plane, and things like people being allowed to not wear their masks while they're sleeping and eating on the plane. I mean, I guess you can't wear a mask when you're eating. But the air itself is not really the really big concern on planes. And like I say, an indoor business that invests in proper ventilation systems, might be okay. I mean, I would say again, physical therapy would, I guess they could move their equipment to the parking lot if they really needed to. But I think physical therapy is one of those things that's health building. Whereas I think, sitting indoors in a restaurant is kind of optional. And you can always do takeout and support the restaurant. So for restaurants, I still say do it takeout. But I think when you need exercise to build your health, I think there may be a little bit more justification. And there are ways, even if you have to do that in an indoor facility, the facilities have mechanisms to keep that environment as safe as possible by, keeping the number of people inside to a limited number, and, by making sure they're highly ventilated and so forth. So,
Thank you, Rick. And somebody asked about the best disinfectant to clean equipment that other people have used.
Yeah, so if you use a 70% ethanol product, that's sufficiently strong. Anything that's 70% or higher is strong enough to clean equipment. I've actually just, diluted some bleach in a 1-to-10 ratio, and I just use dilute bleach. Bleach kills SARS-CoV-2 dead, really. I mean, the nice thing about SARS-CoV-2 is it's really easy to destroy it. It's not a robust virus like other kinds of viruses or even like staph bacteria. It's a very easy virus to kill. So dilute bleach would also be fine if you needed to make your own thing, but I would just look for any hand sanitizer that's 70% ethanol or higher is fine. That's strong enough.
Thank you. There's some other questions that came through on chat. If you could choose about risk reduction, Regeneron, HIV is a priority group for vaccines. Any news on reinfection? Someone asked about to define RNA. And one of the studies thought that the person thought the study had a very small sample group than the entire test group. So you choose. Did I lose you, Rick?
Rick's
there you
muted
are.
right now. Rick's muted.
Can you hear me now?
Yes.
Okay. Actually, the vaccine studies, the RNA vaccine studies, were tens of thousands of patients, so they were adequately powered. But the ultimate number of patients who contracted COVID wound up being only like about 100 of them. But most of the patients who contracted COVID were in the placebo group. But there was adequate power in the size of the studies. There was, I think, ultimately when Pfizer analyzed their final data to apply for their EUA with FDA, I think they did have ultimately one vaccinated person who wound up in the severe COVID group, which I think by severe COVID, they probably mean COVID that needed to go to the hospital. But 90 out of the 95 total cases were in the placebo patients. So that's a very strong protective effect. Keep in mind that these vaccines aren't intended to prevent infection from happening. They're intended to prevent illness, which is not quite the same thing. It is, definitely possible that people will contract SARS-CoV-2 infection after they've been vaccinated. The goal of the vaccines isn't to prevent you from getting the virus. The goal of vaccines is to make sure that if you get the virus, you don't get sick enough to need a hospital, which is an adequate goal. Although it does raise questions for me about whether mild infection in a vaccinated person could still produce long COVID syndromes. And we don't have enough information yet about that to really know. And it's going to be some time before we sort all of that out. So, we just need to kind of watch this space and keep an eye on and, continue to ask those questions. All of that's being analyzed and we'll know more as we move forward. In a perfect world, we wouldn't have people dying left and right and we'd wait and get an answer, but we're going to need to move forward with vaccination because even if natural infection in vaccinated people can still produce some complications, we do know, for example, that the organ injury in a lot of folks is associated with having had severe COVID, and it does look like the vaccines prevent that. So I have a feeling that we'll see less risk of complications from infection, but I can't say right now that no vaccinated people will get long COVID. I don't think we know that yet. We'll need more information. Because remember, this virus literally was discovered 370 days ago. So, how it affects the body and all the organ systems, we're still at while we've seen against. I did see that comment about the Regeneron treatment. So the monoclonal antibodies are different from vaccines. The monoclonal antibodies are treatments. They are antivirals. And there's Regeneron has something that contains two antibodies. And one is casirivimab, and the other one is imdevimab. And so those two antibodies used together are a treatment. And the trick of those, and also Eli Lilly has one that's called lanbinivimab. But all of these are antiviral antibodies. These are basically what they did was they took antibodies from people who fought off COVID and found the antibodies that were most protective, and then they made synthetic versions of them and made a bazillion copies. And so the treatment is you get infused with a bazillion copies of this protective antibody from somebody who fought off the virus successfully. And these antibodies are supposed to be antiviral and prevent the virus from invading you and causing problems. And they do appear, we've seen a handful of people get emergency treatment. They've been in small clinical trials. The trick of those, similar to the Gilead drug remdesivir, is how do you get them into people in that first week when the virus is attacking them? The trick of it is you've got to identify people have a new SARS-CoV-2 infection in that first week, because the first week is where the virus invasion happens, and that's where you need an antiviral. Once you're in week 2 or 3 and starting to get sick, they don't do that much. In fact, the companies were told to stop doing studies on people who are really sick because, the horse is out of the barn at that point. We need, and there's a lot of, I've been talking to ID colleagues around the country about the logistics of getting these monoclonals infused into people. How do you identify the patients early enough in their COVID that they could still get a benefit from these drugs? And of course, these monoclonal antibodies are super expensive too, so they're not cheap therapies. So, they just highlight all over again. None of my patients at Free Clinic are going to get those antibodies. And they are the ones that are getting hit the hardest with COVID. So we've got a country that's created all these Star Trek therapies that cost $1 bazillion. But in the meantime, we're not even doing the basics on wearing masks. And a lot of the folks that are getting hammered left and right by this disease don't have access to care that would let them access all these Star Trek therapies anyway. But there is a lot of logistics being worked out right now about how to get those monoclonal therapies into people early enough. The Gilead, which did remdesivir, ironically, it's an intravenous therapy given in hospitals. Well, by the time you're admitted to the hospital, you're in week 2 or 3 of your COVID, and the antiviral is not going to do very much for you. In fact, in the studies that showed any effect, the greatest benefit was seen in folks who were still not that sick. If you're needing high flow oxygen or you're needing a ventilator, you're already too far gone for the remdesivir antiviral to help you. So Gilead is working on inhaled remdesivir and injectable remdesivir that could be given in a doctor's office, so we can get that drug into people in their first 7 days of infection, rather than getting to them when they're in the hospital, which is 14 to 20 days into their infection, which is too late to probably do them any good. And I hope I answered that question adequately.
Yes.
And there were still a
Rick,
few more. Yeah.
speaking of injections, somebody asked about the new antiviral for HIV injections that are once a month. Should we be stampeding to using that?
Well, I mean, it's very exciting, obviously, and cabotegravir is in the preferred class that we now try to start people on with the integrase inhibitors. Does everyone need to switch? Well, what I would say is, I always use the metaphor of trying on shoes when you're talking about antiretroviral therapy. When you go in to see your doctor and they start you on therapy, it's kind of like when you go into the shoe store and it's like, well, if you're going to be a basketball player, then we might want to give you sneakers. If you're going to dance ballet, you may need slippers. And I always tell patients, as your doctor, I'm going to make an educated guess about what kind of shoe is going to fit you the best based on what I know about you. But I might guess wrong. And in the same way that the first set of shoes you try on in the shoe store may not be the ones you walk home with, I have had occasions where I've started somebody on therapy and a month later I have to switch their cocktail. Maybe because their drug resistance test comes back and their virus is resistant to something I started them on. Maybe because they're getting a side effect that's unpleasant and doesn't work for them. So, does everyone need to switch to the injectable therapy? No, but who may think about the benefits of doing that? People who struggle with their adherence should think about it. Folks who are, frequently missing their doses, as a provider, those are the folks where I think coming in once a month, if they can make their monthly visit, that's going to be, or their visits at intervals. It's really every other month. Those folks are going to be more likely to benefit because they're struggling with pill-based regimens. But if people are doing great on their, small molecule pill-based regimens, there's no advantage to switching to the injection. So I would say it's, as with the shoes, it's individualized. If you're a ballerina, wear ballet slippers. If you're a basketball player, wear your sneakers. It's going to depend on the patient. But if you're doing okay with your current therapy, I don't see right now any obvious advantage to switching to the injectable. But there are folks who struggle with their adherence. Those are folks where that would be a very reasonable thing to talk about with their doctor.
Thank you. I'll let you look through the other chat
Yeah.
questions.
Yeah, let me look at a couple others here. Will the antibody therapies, the monoclonal antibodies, be available through insurance? Yes, eventually I expect them to be. It looks to me like, it's going to take probably some time for the insurance plans to acknowledge the therapy. I think we're still at the phase where, infusion companies are still trying to figure out how to make those therapies available to eligible patients. So I'm not aware of any, companies locally making those available yet. I'm mostly doing outpatient stuff at the free clinic, and we don't have access to any of that because all the patients pay out of pocket for their therapy. So we're not going to be using monoclonals over there. But I've been meaning to kind of catch up with some of my clinic-based friends who are at clinics that see insured patients to sort of find out, what they're hearing about access to these things. I heard, for example, that in Orange County, VNA was offering to do infusions where they could come to a patient's house and put in the IV and give the dose. So yes, I do expect that those things will be available in the near future, but I haven't heard any specifics yet on that. And that's a good question, but again, kind of watch this space because we'll know soon. Can recovered COVID patients become reinfected? Yes, we've had a couple handfuls of cases that have been definitely identified. The way we know they're reinfected is that we had genomics of their original strain collected and analyzed, and then they got sick again, or they look like they got sick again, and their virus was able to be analyzed. Maybe their doctors suspected this was maybe a reinfection, and so they were able to send samples to a scientist to check, and it was a different strain, and so that suggested that it was a reinfection. A lot of the reinfection cases, in addition to people who shed virus for many weeks, which is unusual, often have immunologic disorders, although not all of them. The first death from a COVID reinfection happened in, I think it was Denmark, And the lady actually had a condition called Waldenstrom's macroglobulinemia, which is a lot of jibber jabber, but just she had a blood disorder, kind of like a blood cancer, kind of like leukemia, but not quite as bad as leukemia. But she had a blood disorder, an immune disorder, and that's probably why she was able to get reinfected. And it probably was also why COVID was able to kill her. But we haven't seen dozens or hundreds of reinfection cases. We've really only seen a few handfuls. Shane Crotty's work in La Jolla, looking at people who've recovered from COVID, shows that, the vast majority of folks, 8 months later, still have really good immune responses. Antibodies, T cells, all show that they are tuned up to fight off COVID. So that suggests that, there were probably, I'm trying to remember how his table looked, but there were maybe like 7% of people that were already showing waning levels, but 93% of the samples looked like they had really strong immune responses even 8 months in. So that suggests that the vast majority of people are going to have probably years of immunity. Somebody wanted to ask about the mutations in Denmark and the minks. How likely will COVID have mutated versions spread worldwide and potentially be resistant to vaccines? So as you probably know, like Denmark killed off like millions of minks when this happened. There was a great podcast in This Week in Virology, which is what nerdy people like me listen to when we listen to podcasts. And they're hours of just nerding out on viruses. But there was a huge podcast by This Week in Virology on what's going on with the minks. And they talked to the scientists who were studying what was going on in that outbreak. And so there's a couple of things. One is, those of us who've lived in the world of HIV are sort of accustomed to the idea that our virus is furiously mutating at all times and getting around our therapies. And most viruses don't do that at the level that HIV does. So while it is true that we've watched certain evolutions in COVID, part of that is because the SARS-CoV-2 virus is in tens of millions of human beings around the world. So it's getting plenty of opportunity to evolve because it's infecting pretty much everybody because nobody's got pre-existing immunity to this beast, except for maybe a little bit people who had SARS-1, we think maybe have some pre-existing protection. And maybe some people who got other kinds of benign coronaviruses that cause head colds, although we're not entirely sure. But the mink situation was concerning just because there were mutations in the area of the virus that is targeted by vaccines. And that is why they jumped on it so severely and decided to basically eliminate their mink industry so that there was not further chances for this to bounce out. Now, what they did see was a bit of back and forth between the workers on the mink farms and the minks. In fact, this is why it came to attention, because the workers got it, virologists studied them, and started to figure out they were getting it from the minks, and the virus was evolving differently in the minks than it was in the humans. So the concerning mutations that evolved in the minks and jumped into the mink workers have petered out. So we're not seeing those spread further into the population over there. But we don't want to give it an opportunity to do that, and that's why they've decided to basically eliminate 8 million minks, who will go to mink heaven so that they don't create an opportunity for, God bless them, but they don't create an opportunity for this virus to evolve further. But I think this gets back to this business of this virus, weirdly isn't, most of the time viruses are very unique to a host. HIV 1 and 2 only infect human beings, and with great effort, a few kinds of monkeys that we work with in the lab. But mostly in the monkeys, we use SIV, which is a similar virus that HIV evolved out of, but is not HIV itself. In fact, HIV-2 and SIV are really close cousins. But we're so used to viruses being very precise about which species they infect. And we don't usually have to worry, for example, about getting viruses from our cats or viruses from our dogs for the most part. But SARS-CoV-2 seems to be able to infect a broad spectrum of mammals. The minks are particularly susceptible, as are cats. Cats can get SARS-CoV-2, they can die of it. Dogs can get infected, but they don't get very sick, and they don't seem to be able to produce enough virus to spread their COVID to a human being. We don't know absolutely, and I never say never when it comes to medicine. You get a million infections, you'll see everything eventually. But for the most part, it doesn't look like dogs can transmit COVID, even though they can get infected, they don't get super sick. Cats get sicker, and cats probably can spread it to other cats for sure, and probably to humans. I'm personally worried about all of our primate species in the wild, because we got gobs full of humans, but we don't have very many bonobos, chimpanzees, or gorillas. They're all endangered, and they are very close relatives of us. They would potentially be extinct by COVID if they get it. So I'm actually very worried that humans who are, poaching those animals or wandering through their territories may infect them. There are other mammals that can be affected by SARS-CoV-2 as well, but right now it doesn't look like any major livestock are susceptible, except what I've mentioned. So,
Rick, thank you.
Yeah.
We're coming up on an hour. Now, last time we had you, you were gracious and you went an extra 15 minutes. So I don't know how long your voice is going to hold out, nor how long people's minds are going to absorb before they all explode with the wealth of information.
Should we give maybe like 3
you're
more
giving
burning
us.
questions? I tried to hit as many in the chat as I could see, but maybe you can see, Jonathan, ones I missed.
I'll look. Again, is any of the antiviral medications we take for HIV going to be helpful in COVID?
We looked at this, 6 months ago, and for a while, for example, people thought Kaletra could be a treatment, but that was included in the Solidarity study, and it did bupkis, so no. And I know people got really excited about the study out of Spain that suggested that old style Truvada was maybe protective. But you know what? I plumbed the depths of the data in that study, and I gotta say, I think the reason why it looked like the Truvada patients were protected had more to do with statistical flukes and a small number of people in that particular category, because there aren't very many people still on regular Truvada, because most of them have switched to Descovy. So I think that the reason why we didn't see a lot of Truvada patients getting admitted with severe COVID was because there weren't very many people on Truvada to begin with. I mean, granted, it looks statistically like maybe there was a protective effect of Truvada, and I know people have talked about that, but in the test tube, it does nothing. Not even as much as Kaletra does. So I'm a little skeptical that there's actually any meaningful biological protection from Truvada. I think the data that sort of suggested that it was protective was more of a statistical fluke. And that's why when we do studies, we always have these scores on the results that sort of say, like, what's the chances that this result isn't because the drug works, but just because of a fluke? Maybe it does nothing, and just by happenstance, everybody was going to get better anyway, and they did, and we thought it was a drug, and it wasn't the drug that did it. We always score out our results as to how likely is it that this was just a fluke. And, it has to be a pretty low score. It has to be less than 5% chance for us to publish the results as being statistically significant. But, there's always a 5% chance that, maybe it was just a fluke. That's why the FDA requires at least 2 studies with statistically significant results before they approve something. So I'm not really thinking that a lot of the existing HIV drugs have much to offer in terms of COVID treatment or protection. But I know that was talked about. Having looked at the Spanish paper, I don't think Truvada actually does anything significant. I think that was more a fluke.
Let me put 2 of the questions together. If one got invited to a Thanksgiving dinner indoors where everyone was given a face mask or face shield mask to wear, would you consider going?
No, because you're breathing their air. And unless they have a MERV 13 filter and high ventilation air system, all that air is going to have people's air breathing out in it. And if anybody's got COVID, you're going to have a concentrated virus around that dinner table, and everyone else is going to get exposed. Some people are going to get COVID. So the face shields are good for protecting the eyes, but you need to be masked up. I would say that if I were to do any meal with somebody who's not in my personal household, which is Daryl and my 2 dogs, it would be in the backyard, seated at least 6 feet apart, with everybody having worn a mask on the way to the backyard. And I would keep it short because the longer you're kind of lingering around the dinner table, the more potential there is for swapping air. And that's what's dangerous. And remember, there's nothing magical about 6 feet. It's not like, a person who's actually like visibly coughing can project, their droplets 26 feet away. So, I mean, it's certainly, this goes without saying that, nobody's got suspicious symptoms. But as we all know, the majority of transmission events are from folks who don't yet have symptoms and don't realize they've got COVID. And then they call you 2 days later after the dinner party and say, oh, hey, I just got diagnosed. I just had a doctor colleague who works at Free Clinic who just standing outside next to a neighbor talking for half an hour wound up contracting COVID from the neighbor, and they were outside. So this thing is exquisitely transmissible. So, this gets back into, sort of what are the people that you're around doing to protect themselves? I would feel if somebody's like never leaving their household and doesn't live with anybody and is getting all their groceries delivered, I don't think of them as being very much likely to give me COVID because they don't have any exposures. But somebody who's having to go to work and maybe is going to the gym and so forth, they're plausibly going to, get exposed, and they could expose me. So, it's not just what are the physical conditions of the dinner, but like, what are all the other people around the dinner table doing in terms of their potential exposure? If somebody's hardly ever leaving their house, then they're not likely to expose, to harbor COVID, and that they may be less risky as a dinner partner than somebody who's still going to work, still, out and about. That's something that also needs to be factored in. But no, I would never sit inside for a meal, never. Right now.
It sounds like this would apply also for Christmas, Hanukkah, Kwanzaa gatherings.
I told everybody in my family we're Zooming Thanksgiving and we're Zooming Christmas, just like we Zoomed Easter. And, we'll probably have to Zoom Easter next year. But, as we get into the holiday season in 2021, most of us by that point will have been vaccinated, and it will be a different story.
I'm going to tell the group if anyone has any further questions to raise your hand, either electronically or just physically raise it, and I'll unmute you so you can ask Rick directly. Someone asked, what is the RO factor for COVID?
Right. So that is a score for how many people, how many new cases of COVID result from an existing case. And in order to get shrinking numbers of people having COVID in your population, the R0 score needs to be less than 1. If every person with COVID creates another person with COVID, then your levels of COVID in your population stay steady because each case causes another case that causes another case, so it keeps going. If each person in your population infects 2 more people, then 1 case becomes 2 cases, becomes 4 cases, becomes 8 cases, becomes 16 cases. That's called exponential growth, and that is why all of our hospitals are now overwhelmed. So in most places right now in the United States, the R0 is somewhere between 1.2 and probably 1.8 or higher. In some places it may be as high as 3. I think on average, we suspect that it's, for COVID somewhere between 2 and 3 under most circumstances, because some people are masking and some people are doing some of the restrictions. It's less than 2 in a lot of US states. To my knowledge, it's only below 1 in like Vermont. So most of the states are still having a net increase in their COVID cases because their R0 scores are above 1. But we think, COVID in your population with no one doing anything like hand washing, masking, limiting their exposure, staying in, things like that, the score probably running wild would be between 2 and 3 new cases of COVID for every existing case. And that's why it explodes exponentially. That's why Dr. Loftus was running around with bug eyes for most of February, March, and April. And everybody thought I was crazy. And it's like exponential growth, exponential growth. don't you people understand science? You should be freaked out. And nobody was listening. And it's like, I was frantic. My off days were like 14-hour days calling people working on multiple projects because, it's exponential. It goes from nothing to insane levels of disease in almost no time at all because of this. At one case goes to 2, goes to 4, goes to 8, goes to 16. So hopefully I kind of answered that question. What's the next one?
Okay, well, before I do the next question, I want to remind people that LKAPS is a nonprofit organization. Your Evite invite has a button to press to make a donation. We'd be very happy to see some money coming in during this difficult time where we're not gathering and hitting people up personally. The question is difference between KN95 and N95 masks.
Yeah, so N95s are the considered gold standard medical grade. And when those are placed on a medical provider with a fit test, where they actually have you go into a hood and actually spray scented material. And, if your mask has formed a perfect seal, you should not be able to smell the odors. In other words, it's perfectly sealed and protecting you from virus particles getting in. KN95s are considered to be kind of like a knockoff. They're a cheaper design. They're usually cheaper materials. They're intended to be able to confer the same kind of protection. I haven't seen any comparative data. I mean, to be honest, even in the hospital, we wound up using so many different models of N95s that although I had a fit test with our traditional mask, I soon moved on to we had like 4 different models of N95 masks. So, I was not fit test for all of those. So I don't even know how well they were at protecting me, but that's what I had. So that's what I used, and I didn't get COVID. But I also, of course, was using a face shield. But KN95s are considered to be, they're more accessible to laypersons. I would say that the difference is that while we do have medical providers sometimes using their N95 masks multiple times, we had a paper that came out this week that showed after about 2 usages, about half of the masks failed their fit test. They actually tested them multiple times as people wore them throughout the week. And after about 2 uses of an N95, they weren't nearly, about half of the masks failed to protect from particles, which is a little scary because I've had people who are using masks 7, 8 times. I had masks that I probably used at least that many times. KN95s, I haven't seen any data on protectiveness, but I would say most people would say those are a single-use mask. You put them on, you wear them for a few hours, you take them off and throw them away. They're probably not capable of being reused.
In trying to be on the downhill slide to close this out, can you comment about what's happening in Coachella Valley and differentiate between the East and the West End and hospitalizations? Because there have been reports about how many cases are reported and then how many deaths there are, but they don't say, oh, these were nursing homes, these were kids, these were...
Right. Well, initially we had really high rates of COVID in this part of the Inland Empire. And then I learned that half of our cases were actually from the prison. And certainly initially we were seeing huge numbers of cases at the nursing homes. And that's still true, or was true, in the first surges in Canada, for example. I have a lot of Canadian scientists on my feed, and they've been talking about that in Ottawa for a while. In the Coachella Valley locally, where we're seeing, for the most part, really high rates still of new infections in the last week or so have been in the East Valley. So that's Mecca, Coachella, Indio, a little bit in Cathedral City. But in terms of Middle and Western Valley, it's not nearly as hot and heavy as it is in the East Valley. But we have been seeing rates creep up. In terms of death rates always lag, and they lag by about a month. So when you see case rates go up, everybody says, oh, but the death rates aren't going up, because we're doing such a better job keeping people alive with COVID. And it's like, no, it's pretty to think so. But as a frontline COVID provider, I got to say, no, that's not really true. I mean, yes, we've learned a few things that do help us keep people alive better with COVID than was true in March. In fact, I had a young man who came in June who probably would have been dead if he'd come in March. But by June, I knew enough from the international studies to know how to keep him alive, and he survived. So when I hear people say, oh, we don't need to worry because we're keeping people alive, well, first of all, it exacts a toll because your providers are still stressed out of their minds trying to keep those people not dead. And it's not exactly a low stress job. So it's still very taxing to keep people alive, although we are doing a better job than we were at the beginning of the pandemic. But much better than having to keep people alive who've got, severe COVID is, how about not getting COVID at all because people stayed home and wore their masks? So that's what the medical providers are trying to say. But we have seen, rising case rates in the Valley in the last month. It's continued to go up and up and up. The Eisenhower epidemiologist has projected a severe surge that will continue to escalate over the next month. So we're only going to see increasing rates, and the death rates will definitely go up because that has always been true in every region that collects data. It always lags by about a month. So the death rates will go up here despite our best efforts with therapies. I'm hoping that, with some of the monoclonals and other things getting deployed, we'll have some ability to mitigate some of that, but there's a lot of logistics involved in doing that. And a lot of the folks that need those therapies are not going to necessarily have an easy way to get them. That's all still being worked out.
Well, Rick, thank you so much for sharing your vast knowledge with us. So can everyone give him a round of applause?
My pleasure. It's always a pleasure. So
maybe we can have you back again in January or February. It seems
Sure.
like there's so much to know if you're still having some free time and not snapped up by some organization to work for.
I'll always make time for LKA. So, just everybody do your best to stay safe, keep looking after each other. This organization to me has always been an example of community, keeping people educated, making people know that they're not alone in dealing with everything, understanding the importance of mental wellness, not just physical wellness. So, keep on doing what you're doing as an organization and looking after one another. We'll get through this. We're going to get on the other side of this. We're going to get vaccinated. We just need to make sure that as few people get natural infection between now and vaccination as we can pull off, because natural infection is a lot nastier than getting a vaccine.
Thank you.
Yeah.
LKA is not having any official Thanksgiving event. Some people may go to Ruth Hardy Park and other people may drive by and wave, but people would have their own blankets and picnic far from each other. We're not really encouraging it. We're trying to support the health of people. So we may have a delayed Thanksgiving sometime in June. Who knows? They do Christmas in August. So what's to say we can't do something out of sequence?
Exactly.
Please give our best to your husband. That's a subtle way of letting people know he's already taken. And and our best to your family.
Thank you so much, and love to all of you. Take care of yourselves, and I'll see you guys maybe in January.
Thank you. Thank you.
Good night. Thanks, Rick.
Bye, everybody.